Welcome to JFK University Hospital Health Spot. I'm your host, Dr. Kishore Ratkalkar, Pulmonary Internal Medicine Physician, Medical Associate, Central New Jersey, Hackensack Medical Group. With me today is Dr. Killol Patel. He is the Medical Director of Lung Nodule Program, Hackensack Meridian Health, Severe Emphysema Program, board certified in Pulmonary Internal Medicine and Critical Care. It's an important topic today, a topic which I think needs further explanation to our viewers, and that is about lung cancer and lung nodules. Every patient that sometimes, they're concerned, the doctors say that they have lung nodules, and that's where today's topic is based on that. We have heard about screening for colon cancer, prostate cancer, breast cancer, and other types of cancer, but lung cancer screening is not well recognized still. And it is a very important topic for our viewers to understand what these lung nodules are. Not all lung nodules, you shouldn't be scared, are cancers, and most of them are benign. But here with me to explain the lung nodule and the lung cancer screening, I have with me an expert, Dr. Killol Patel, who is well versed in lung nodule programs, lung nodule screening and evaluation, therapeutic interventions, and interventional bronchoscopy. It is my honor and privilege to welcome Dr. Killol Patel. Dr. Patel.
Hi. Thank you, Dr. Ratkalkar. Thanks for having me over here. I'll be more than happy to go over the lung nodules and what they mean and the lung cancer screening part, as you mentioned, per se. So regarding lung nodules itself, so these are commonly referred to as spots on the lung whenever somebody gets an X-ray or a CAT scan.
Sure.
They are told by the physicians that that's a spot on the lung. As you rightfully mentioned, that majority of them are not cancer, about 95 to 97% depending on which study you look at. Our lungs are one of the organs which are constantly exposed to the surrounding air, what we breathe, and sometimes it's not actually pretty good and it might be harmful to the lungs. So when the lungs try to repair themselves, sometimes they can end up with some kind of a scar tissue, and that can be presenting itself as a lung nodule. Whenever you see a lung nodule in the lung, it's usually one of the four things. It could be an infection.
Sure.
It could be from inflammation. It could be scar tissue from a previous infection or inflammation, or it could be cancer per se in a small group of people. Then that's the majority of the things. So that's why when we look at it, we look at the complete clinical picture per se and where they fit in that, and then we look at the size of the nodule, the shape, the appearance, the location, and then we come up with whether it looks high risk for cancer, intermediate risk, or low risk. And majority of them, as you know, fall in the low risk group per se, and which we just keep a watchful eye on them if required based on the guidelines, what we know of. At the same token, the lung cancer screening program, what you mentioned, is very important because, as you know, very few people get screened, especially in the state per se. It's in the single digits to like low teens, depending on which survey you look at, especially in New Jersey. I think so the last survey came out, it was like 8 or 12% of eligible patients are getting screened right now.
Unlike for colon cancer.
Or mammograms.
Mammograms or breast cancer, yes.
Yeah. So if you look at it, like in mammograms per se, you need to do roughly 2,500 to 3,000 mammograms just to save one life. But whereas for lung cancer, even if you screen 300 people, you can save a life.
Sure.
So it's remarkable difference with that.
Yep.
I think so the discrepancy is there because there's a taboo attached to smoking per se.
Right.
Some people think that, oh, I'm smoking and that's why I got it, but there's no stigma around it. Even if you are currently smoking or have quit smoking per se, you should be screened for it. There are various studies, as you know, which were done, which showed that if you have smoked for about roughly 20 years, pack a day or so, and between 50 and 80 years of age, and if you if you quit smoking less than 15 years or you are currently smoking, then you should be screened for it with an annual CAT scan.
Sure.
And as you know, the CAT scan has no needles involved. You go and it takes 5-10 minutes and then you're done. They just ask you to take a deep breath. That's about it.
Yeah, based on the CAT scan, it will define the kind of nodule size you have, and whether those nodules need to be followed or not to be followed by the criteria that we use, the Fleischner's criteria, as to what is important for you. But if you are a smoker, Dr. Patel, it is important to have serial CAT scans done, not just once, so that you can monitor them.
Exactly.
So if in general terms, without being too specific, for our viewers, as to at what point they should be concerned about these lung nodules that may be of a problem, and then they should come to somebody like you for further evaluation.
Normally, the lung nodules will be followed by a pulmonary physician like you, per se, who will look based on the Fleischner guidelines. But whenever the appearance changes in something what we call a spiculated, per se, or it starts getting bigger, close to a centimeter, or something that is growing, per se, more than 6 millimeters, and it keeps on growing, then we are a little bit concerned about it. Still, we try to risk stratify them as we said, that whether they are at a higher risk for developing lung cancer versus intermediate or low. We have some blood works, per se, which we can do to help us to get to that. But if at all they are fitting in the high risk group, then we would go ahead and do some sort of a biopsy on them to figure out.
So those are the ones who are really current smokers or recent ex-smokers, but who have smoked more than 20 plus years, pack years, I mean. And they are at a risk.
Exactly. And also depending on some of the occupational exposures, per se, so that can also play an account.
So in that modality is the low-dose CAT scan.
Yes.
So you want to expand on that as to what a low-dose CAT scan is and how important it is, just like you talk about mammograms, Cologuards, you're talking colonoscopies and all that.
Exactly. So exactly. So as I mentioned earlier, per se, like when the colonoscopies or mammograms are like mainstream right now, everybody talks about it, everybody does it, and the reason being, that is good at like outreach and marketing about it too, like everything else in America. So that's actually pretty good. But at the same token, lung cancer screening is very, very effective, per se. It saves lives. The numbers are mind-boggling. Like as I said about mammograms, between 2,000 to 3,000 patients. Colonoscopies is also around the same range, 1,500. And whereas this is only 300. The low-dose CAT scan is a CAT scan with a lower dose of radiation in it, per se.
Very low risk.
Yeah, exactly. It's very low risk, per se. The radiation amount is negligible. People don't realize that even when they take a transatlantic flight, they are exposed to radiation, per se. So so it's not like that.
No, I understand.
And some patients also justify saying that if we had an X-ray done, that would suffice. But in reality, an X-ray is just a one picture, whereas on a low-dose CAT scan, we take about 300 pictures of the same thing, which gives us a much better definition of what's going on inside.
Yeah, I appreciate that. So any long-term smoker, and especially who are at age 50 or so, I would recommend you speak to your doctor, and maybe you should get a low-dose CAT scan. We'll take a short break now, and we'll come back more to this program with this segment talking about interventional bronchoscopies, diagnostic testing, which Dr. Killol Patel is an expert in, and we'll expand on all those topics after the break. Thank you so much. Welcome back. Dr. Patel, we were discussing lung nodule. Let's take it a step forward. Now that we found a lung nodule, which is very suspicious for malignancy, meets the criteria for malignancy. When I was in training many years ago, I won't tell you how many years ago, we did not have the technology that we have today. And the technology that we have today is a game changer. And the new ones that we have, especially in your field of expertise, interventional bronchoscopy, we do have navigational bronchoscopy.
Yes.
Could you explain to our viewers what navigational bronchoscopy is, and the indications for that, and where we have progressed and how far we have progressed with this technology in identifying lung cancer?
Definitely. So yes, we have come a long way, and as we were talking about during the break per se, it's fascinating in that regards. Previously, back in the day, we could only do a bronchoscopy, go down with a camera and try to biopsy a lung nodule, which is very big. However, the smaller nodules, we'd had to wait for them to grow a little bit bigger, or try to go with a different modality in which we go in with a needle from outside of the chest.
Correct.
And get a biopsy of it. However, the risk of puncturing your lung is very high. As you know, it's anywhere from 20 to 25% in that case. So now we have a modality in which we take your CAT scan and then create a three-dimensional tree from it.
Sure.
So we can see what it looks like, and then we use your airways, which are already there, and with a small camera we can go all the way out to the periphery of the lung. At JFK, as you know, we have the ion robotic system, and at Bayshore we have the Galaxy system. Both of them are pretty phenomenal, and we can go after lung nodules which are as small as 6 to 7 millimeters in size.
And in the periphery of the lung.
In the periphery of the lung.
Correct.
And we have gotten positive answers with that.
Right.
And it's very, very safe. The risk of lung puncture is anywhere from 2 to 4%. In historic perspectives, in our institutions per se, our rate is even lower than that.
Sure.
In that regard. So they're very safe. We can do it in a single setting. If at all it is cancer, we can even stage the cancer at the same time. We use a special kind of a bronchoscope called an ebuscope per
Correct.
se.
So you do the lymph node sampling.
Lymph node, we can sample the lymph nodes, and we can get an answer about what the stage is too, so we can get them to therapy sooner, because I think it's very anxiety provoking of just having to wait
For the
for the results and for another testing to be done before which any therapy can be decided. So these are very the both ion and the Galaxy system work by creating the three-dimensional tree. So we have a GPS for the lungs per se, and so it can navigate. It tells us where to go, where we are. At the same token, we have something called a ScioSpin. It basically shows us in real time that are we in the nodule or not, and then we can get an answer for that.
Yeah, because in the past we would miss up, just because we didn't have the proper imaging.
Imaging, yes.
We were not able to be in the nodule.
Yes.
And
we'd be assuming things per se at that time, because if we didn't, as you said, we just had fluoro at
right,
that time.
but we used to do washings and brushings and trying to get that. But now with this technique, you can
See
laser focus it, go right where you want to
Yep.
go, and do the biopsy. So in these situations, the diagnostic, how many more patients are diagnosed this way compared to the traditional way of doing it?
So if you look at the accuracy or the yield of it
Yeah.
per se, so when you used to do transbronchial biopsies, or going down with the camera and just doing a
that we
biopsy,
used to do. Yeah.
it was anywhere, depending on the size of the lesion. If it was more than 3 centimeters, it was anywhere 65 to 75%.
Correct.
Per se. If it was smaller, it would be even much
Much
lower,
lower,
going down
right.
to almost 50%
Right.
in some cases, if less than a centimeter. Whereas when you look at these navigation platforms, the accuracy rate is about 95 to 90%, and in historic, like in all the studies that were done, but in our experience, it's even higher per se, because we have an excellent team that works with it to follow it. We have been following these patients who
So
we did a biopsy.
really, it's a game changer.
It's a game changer.
It's a huge game
Absolutely,
and this is all available at Hackensack Meridian
Yeah.
Health in Central New
Central,
Jersey,
yes.
at JFK University Hospital and
Bayshore.
and Bayshore Hospital.
Locally.
In this same thing, we know not cancer, but you have interstitial lung disease.
Yes.
Interstitial lung disease is a major thing, and a lot of people do get affected by it. It is scarring of the lung tissue, and then we need proper evaluation so we know whether it is an inflammatory process, it is, and sometimes a malignancy is hidden in
Yes.
it. So how do you approach that?
So it's especially become a bigger issue after COVID per se, when we have a lot of patients with
Right.
scarring and stuff like
Right.
that. So back in the day, people here, we had to send them for open lung biopsies or surgical biopsy, in which either they did it robotically or something, and however the complications and the morbidities was very high. They had to stay in the hospital for a few days and so on and so forth. However, now with the advent of new tools that we have, we can do something called a cryobiopsy, in which we can get a bigger lung sample per se, which can help
Right.
us diagnose whether
Sure.
what kind
Sure.
of scarring it is and how to treat it. At the same token, we also perform some genomic biopsies, like we take a biopsy and send it for genomic analysis. It can also help us decide what is the type of fibrosis and how we can treat it to slow it down or reverse it in some cases, and how to proceed further. So yes, we have come with a lot of tools, and as you mentioned, yes, we have all those tools available locally. You don't even have to travel anywhere.
Travel anywhere, and then
Yeah.
you can help these patients in
Yep.
terms of treatment.
Yes.
Whether if it is related to chronic lung diseases or somebody with
Maybe.
sarcoid with scarring,
Yep.
those are treatable
Yep, exactly.
and they are reversible.
respond really
And
well.
then if you have the so-called ground glass opacities,
STs.
which is always a problem on the CAT scan,
What to do with it.
what to do with them, and these are the techniques that you can do to help diagnose these conditions. Is there anything else in interventional bronchoscopy which is in the cutting edge now?
So it is per se. So we can also do a lot of procedures in which, like, unfortunately, some group of patients perceive the tumor is growing at an abnormal location.
Sure.
Like one of your breathing tubes is getting blocked. As you know, we have a breathing tube that
Uh-huh.
goes down your neck and divides into two. If the tube gets blocked for whatever reason, there is no way for air to go in and out of your lungs per se. So we have various tools in which we can remove part of the tumor from there in a minimally invasive setting, as well as put something called a stent. It's like a metal.
Yeah, okay.
Metal tube
I got it. So that would help them
with the breathing part.
to breathe better. So we're going to take a short break. Welcome back. Dr. Ratkalkar with Dr. Killol Patel discussing interventional bronchoscopies, the new technologies, managing, diagnosing lung cancer. Dr. Patel, we discussed all the modalities of how to screen for lung cancer. We also talked about interventional bronchoscopy, navigational bronchoscopy, the image-guided procedures, and also on interstitial lung disease and how to evaluate and diagnose them. I want to move a little bit further down,
Sure.
and because there are quite a few patients who are not diagnosed right away. And it's not because they're not diagnosed. Some don't come to see a physician until it's pretty late, when they're coughing up blood, they have severe shortness of breath, they have audible wheezing, that is a
Yes.
noise in the chest, and they can't breathe. And then we find on the CAT scans and our investigational tools, they do have advanced cancer, which is complicating their airways. Do you please tell us what is it that you can do to help these patients get better?
So you're absolutely correct. So sometimes patients don't get diagnosed because they don't seek care early enough, and that's the majority of the times. And again, segueing just one statement, that's why it's important to screen so that you can diagnose
That's
it.
why you do the screening
Lung
if you are a high risk.
if you are at a high risk patient per se. But going back to that, so if at all you have a tumor that's growing in a location which is either bleeding quite a bit or eating away into your airways per se, we have tools in which we can go down with a camera into your lungs and stop the bleeding, at the same token try to remove part of the tumor and open up the airways again so that air can go in and out of your lungs. At the same token, we can also put in metal tubes, or there's something called a stent. It's like a tubular structure. Some of them are made out of metal, some of them are made out of silicone or a hybrid per se. And all of these are done through a camera, nothing cutting involved. Like, we have other very, very fine tools per se on how we achieve these results. They're very well tolerated. And as you can understand, these patients are very sick to begin with.
Sure.
That's why they're seeking help at that late stage. And what this does is it bridges them so that they can tolerate whatever the definitive therapies, either radiation or chemo, and to help them out, and they can tolerate that therapy, and hopefully the cancer can shrink, and they can always take these stents out if need be.
And they'll breathe better.
Exactly. That's the whole
because
point.
it improves their quality of life.
Yes.
By doing that. What are the complications, if any, of these procedures? Because all these procedures, they have some level of complication.
Definitely. So majority of, so depending on which procedure we talk about, so usually whenever we are in the lung per se, the most common risk is some air escaping out of your lung per se, or the pneumothorax. Majority of them are very, very safe per se, but still these complications can happen. If it happens, you have to put a tube from the outside of the chest to re-expand the lung, and the tube stays in usually for a day or two.
It's not if it's managed immediately, it's not
fixed. It's not a major issue, and then it resolves per se.
And they're sent home.
And they're sent home.
Yeah.
Majority of the complications are very, very small per se compared to the other options that they have. So depending on how sick they are, like the last issue that we were discussing about advanced cancers per se, where they are growing
within the major airway.
In the major airway per se, then there is an issue of bleeding. But however, we have tools to help them out, and that's where we are doing that. We are very well equipped. We have a multidisciplinary team, as you know, at the Lung and Airway Center, in which we can deal with this.
This is at JFK University Hospital.
University Hospital. And we can help them out in that. So yes, there are complications which are present per se, but all that can be dealt with in that regards.
And infection is one of the things
yes, exactly.
So what is the role for ablation?
So the there is a new technique that has come out, in which, if at all the patients are not responding to therapy, or they have very advanced disease and they've exhausted most of the resources per se, we can go in with the camera, with the navigation bronchoscopy, what we spoke about, and try to ablate or destroy the tumor cells in that lesion. The theory, the way this ablation happens is, it's something in which the electric currents are fluctuated so that the cells will die in a programmed cell, that like apoptosis, as we call it. And this releases whatever's inside the cell, and the immune systems pick it up and then start attacking these cancer cells across your body, and hopefully you will have a better response in treating those kinds of cancers. And we have this therapy available at JFK Medical Center.
Wonderful, because the other thing that happens is, when the airway is totally blocked, you get recurrent pneumonias, recurrent infections, and you cannot even bring out your secretions or your mucus, and that causes again a cascade of recurrent infections. Thank you, Dr. Killol Patel, for being here today, sharing your knowledge with our viewers, especially when it related to lung cancer, interventional bronchoscopy, and therapeutic modalities. Thank you all for watching. We'll see you at the next episode. Dr. Kishore Ratkalkar.